Good morning again, everybody. My name is Rob McKenna. I'm the Principal Investigator of Training 3, the Region 3 Family Planning Training Center. And it's my honor and pleasure to bring for you someone who's become one of our core faculty, Durain. She is one of the most knowledgeable people about contraception and family planning that you will ever want to meet. We're really excited to have her here. She's been a nurse midwife for almost 30 years. For the last 13 of which she's been the Associate Director of the Nurse Midwifery Training Program at the University of Pennsylvania. And I think by the end of her session, you'll say, wow, that was terrific, because that's what she is. Please welcome Ms. Durain.
Good morning. So as Rob said, I've been a nurse midwife for a long time. I bet I had my training here before just about everybody in the room. And one of my agendas for the day, just so that you know, is to try and undo some old thinking that I'm sure that some of you might have had at some point, certainly not now, about some contraceptive methods and how we might think about reorganizing our office visits and our counseling sessions with our patients before us. I teach nurse midwives and women's health nurse practitioner students at Penn, and my goal with them is to help them think about all the wonderful evidence that we have these days in terms of reproductive health care, and think about how they might apply and acquire some judgment about how to apply that evidence. When I talk to our preceptors, my colleagues, I do it the opposite way, because we all learned what we learned, right? And that was the right stuff then. But we know that quite unfortunately, things change, for better or for worse, and that in this country, it takes 15 years to change providers' practice. We don't have 15 years to wait to change practice to match up with the evidence these days. So I'm hoping that I can help us all think about how we might change a little bit now and think about some new stuff that's out there. So the two things that I'm going to talk about specifically are what we think about as the annual GYN exam, which doesn't exist anymore. How many people here are gynecological providers? All right. So your challenge then as counselors and social workers and the other kinds of providers that we have here with us today is to think about helping us as providers to reimagine what they do when they go and see their GYN provider in the office. Because the days of going for an annual pap smear are over. The days of having to see somebody on an annual basis to get approval for your contraceptive methods are over. And so I'm going to talk a little bit about what that means and what we might do about it. The other thing that I'm going to think about very specifically with you today is how we think about the kinds of contraceptive methods that we call long-acting reversible contraception. So that means implants, Implanon and Nexplanon, and intrauterine contraception, meaning Paragard and Mirena. So I'd like to help us think about how to put all this together today into what we're trying to think about as a reproductive life plan for women. And that's something that we should talk about with every woman that we see every time, right? This isn't something that we reserve for once a year when someone is thinking about a contraceptive method or comes in for that positive pregnancy test. This is something that we should help people try and imagine how they might plan their life in terms of their pregnancy or their not pregnancy times, how to fit in primary care, because we know that very few women these days actually have a primary care provider who's not their gynecological provider. I talk to women about depression. I look in their throats. I talk to them about their headaches. And so fitting all that together with their reproductive care makes all the sense in the world, as well, of course, what you all know in terms of HIV services. So this is a definition that comes from the CDC, and since we're being funded by the feds, we'll talk about the CDC a lot today. But this is what the CDC has put out there as what they're hoping that we all do with women every time we see them. in terms of trying to come up with their reproductive life plan. We know that very specifically there's some really nice tools out there as well for women who have AIDS or are HIV positive, and I'm sure that you're all familiar with this as well. So, how do we get people to talk about this? We help people to think about it in terms of what might make sense for them physically as well as emotionally in terms of being prepared for pregnancy and to enter that pregnancy in as healthy a state as possible. We know that here in this country we have horrible health statistics when it comes to reproductive care. We know that still over half of all pregnancies are unintended. We know that the choices that women make in terms of contraception are mostly short-term. In the most recent statistics that come to us from the CDC, 30% of all women who started to use an oral contraceptive stopped using that oral contraceptive within 6 months. That's terrible. We know that 50% of all women who started to use the patch, Evra, within 6 months decided to stop using the patch. We have to do something about the relationship that women have with contraception, because right now it's not a very good one. We also know that we have terrible statistics in this country when it comes to maternal and newborn mortality and morbidity. We know that our statistics do not match up with the rest of the developed world, and when we break it down by race, ethnicity, and age, that those statistics match those in the developing world. So we need to think very hard about how we can convince women to enter pregnancy in a mindful state, because they're there because they want to be, and in as healthy a state as possible. So we need to think about the kinds of screenings that we do with women and make sure that they're age appropriate. We know that the kinds of screenings that we do with a 15-year-old are very different than the kind we do with a 30-year-old. And we finally have some really good information about how to organize our visits around those. We need to make sure that we're doing health education as well in a very specific fashion. And we're doing it in a way that's acceptable to the woman herself in terms of her culture, her sexual orientation, and her life view. I think to say that women's health care has become a prominent part of the political agenda would be a vast understatement. I think that what happened this week is even more evidence of that. Nevertheless, we have some new legislation and regulation coming out by way of the ACA that's actually giving us ways to legitimately place preconception care, so reproductive life planning, as well as contraceptive care into billable services and hopefully more accessible services for the women who want them. You probably have seen these kinds of statistics as well. This is information from the CDC telling us what kinds of contraception women are using in the United States these days. Up until the most recent survey, the most popular method of contraception was sterilization, female sterilization. Male sterilization wasn't added in. They were always kept separately, female and male. Now, however, the pill, combined oral contraceptives, have surpassed the sterilization methods, but just by a few 100,000 women. They're kind of neck and neck. This slide kind of adds male and female sterilization in together, just to remind us that we need to add vasectomies in there, hopefully. It's still a very small number of men in this country who have a vasectomy, but still, it's the pill that's the most popular contraceptive method that's reversible for women these days. And then you can see how it breaks out in terms of other methods. So thinking about the rest of the world, so widen your horizons here for just a moment. What do you think the most popular contraceptive method is in the rest of the world? Thoughts? IUD. Oh, we're good. Yes, it is the IUD, right? So sterilization is also very popular, especially in the developing world, right? Because it's easy, it's one time, it's private, we can go and get it over with. Pills are not particularly accessible. You have to keep on going to get the prescription refilled. They're expensive. Breastfeeding is certainly up there, but it only applies to women who have just had babies. But the IUD is the most popular method in the rest of the world. But it isn't here. By far, it isn't here. What's that about? Yeah? Right, so the answer was hysteria. I think that's a really good word. Yes, there was an incredible amount of hysteria that went on around one particular IUD, the Durain Shield, and that hysteria unfortunately painted every other method of intrauterine contraception with the same brush. And really unfortunate, because every intrauterine contraceptive method was then taken off the market. And the people in the rest of the world looked at the United States and said, "What's wrong with you? Why are you doing that? That's silly," right? We knew that the problem really was only with the Durain Shield. It had nothing to do with any other IUD that was available at the time or now. But being who we are, we acted in a fairly rash fashion. And it's taken us over 25 years to get back to the place where people feel even a little bit comfortable about thinking about intrauterine contraception with their patients. But we'll talk about that more today. Any other thoughts about why IUD use is so low here? Yes?
I mean, for me, a part of it is, in this country, marketing is everything. And so when you hear people who aren't in the field, I used to work in family planning, I work in HIV and AIDS now, and you hear them say, well, you don't want to put anything up there, and then, it's dangerous, and I just want to tear my locks out. So a part of it, to me, is marketing.
Sure, and the answer was marketing, and it's all about how people perceive the risks and benefits of various methods. When the contraceptive patch first came on the market, it took quite a while for that direct-to-consumer marketing, so for the ads in the women's magazines and commercials on TV that we're also used to now, to happen. And I kept saying to the reps who were coming to the offices and saying, "Why aren't you prescribing this more?" I said, "You need to put an ad in Glamour magazine, you guys. People aren't reading about it, and if they don't read about it these days and they don't hear about it, they're not going to ask for it. And no matter what I say to them in the office, if they're not getting some other kind of reinforcement, either from the media or their friends, they're going to think I'm crazy and they're not going to take it." Absolutely. So it's all about perception these days. And so I don't know what you see in your area, but I saw my very first Mirena commercial on TV last night. I was very excited to see it. It was an interesting commercial. It talked a lot about long-term contraceptive coverage, and then the list of disclaimers that we're all used to with every other kind of medicine and device went on forever and sounded just as scary as they do about Viagra, for instance. But it's out there, so I'm guessing that people are going to start asking about it in a different way if they keep on running commercials like that in the various markets, so keep your eye out. Okay, so when we talk about contraception, we talk to women long and hard about what method works for them, what they've used in the past, what they'd like to use, what they think might work for them. And as we go through all of those criteria, we get to the bottom, and there's likely nothing left, right? Because there is no ideal contraceptive method these days. It just doesn't exist. But if it did, what would it look like? What would be your preference for what the ideal contraceptive method would look like? Oh, come on. I know it doesn't exist, but I know you could think of it. One time use 5 years. Okay, there we go. That's a good one. Okay. And what? Male contraception. Well, that one's a really long way off. I'm going to tell you that for sure. Yes, indeed. Male contraception. Yep. What else? Highly effective, right? It would work for a long time, and it would be highly effective. It would really work. Yep. And it wouldn't have any bad side effects, right? As a matter of fact, it might have some good side effects. I mean, think about the things that women talk to us about these days, right?
Yeah.
Maybe it would have a little something to do with libido, for those of us who are getting a little older and thinking about those issues. Maybe it would do something about other kinds of systemic issues, our skin, headaches, help us sleep better. Yeah? So long-term, highly effective, wouldn't have any side effects that were bad, would have some side effects that were good, as a matter of fact. And it would be cheap. Yeah, it would be cheap. People could get it. What's that? And it would protect us against STDs. Wouldn't that be great? Yep. It would be easy. Yeah. All right. Well, I'm here to say that, obviously, that doesn't exist. But, as we go forward here, I would encourage you to think about the IUDs and the implantable contraceptive methods in that context and see how many of those criteria might match up with those methods. So, what's the most common reason that women who are not contracepting at the time of unintended pregnancy say that they weren't using contraception? They say, well, I didn't think I could get pregnant, right? I wasn't planning on having sex, or I hadn't gotten pregnant before, so I didn't think I could get pregnant now. Or, well, you can't really get pregnant that way, can you? No, that's not really how it works, right? Or he told me that I couldn't get pregnant from having sex with him. Or I got up and I douched right away. Or, I just didn't think I could, or I would, right? We have a wonderful denial happening in this country around contraceptive methods. And again, I'm hoping that by way of talking to women about this early and often, that we can think about how we might intercede into some of that denial and help them think about methods that might keep them away from those unintended pregnancy moments because they weren't contracepting. Yeah?
Well, one of your challenges might be that you would have to be able to talk about sex in a way that women could joyously be aware that they might be sexual and want to do it, and then fit that contraceptive piece in there.
I absolutely agree with you. I think that's a really important piece about it in terms of trying to figure out a way that we can all talk to women about sex in a way that's positive, and that lends to getting away from some of the scolding, judgmental kinds of health education methods that I think that we've tried to use over the past few years that clearly don't work. So I think that's a really important point. So I'm sure that you all know this, but this is a schematic that we often use to talk to people about the various kinds of contraceptive methods that are out there. This is from the WHO. When you talk to people about effectiveness of methods, I think it's really hard to translate numbers into something that makes sense for people. And so sometimes a visual like this makes sense. And I think especially the visual that looks at looking from less effective to more effective. Look at the difference there. 30 pregnancies and 100 women in a year compared to 1. I think that's kind of a dramatic way to paint it for people when they tell you that they're using whatever method is that they're using, off and on, not at all, intermittently, whatever, and help them think about what it is that they might plan for their lives and when they might choose to use one method or another. Because when you ask women what the most effective method is out there these days, they say the pill. They absolutely do, because that's the thing that they're most familiar with, right? It makes most sense. You put something in your mouth, it's absorbed into your system. It's something that's really easy to understand in terms of what we think about how drugs work, as opposed to how all these other things work. You put this little silicone ring into your vagina and it prevents pregnancy. Really? It's kind of hard for some people to wrap their heads around that, and understandably so. So even more so, it's harder for them to understand how intrauterine contraception might work, And the fact of the matter is that we don't know an awful lot about how it does work. We just know that it does. And then even more so, putting this little thing in your arm, and that's going to keep me from getting pregnant for 3 years? Really? Are you serious? And that's what I get back from people. So, as many ways as we can think about how to convey why it's important to think about other methods than the pill, I think is helpful. So 2 years ago, the CDC decided to issue their own medical eligibility criteria for contraceptive use. Until that time, we had been using the medical eligibility criteria from the WHO, which worked perfectly fine. So we asked, why did the CDC decide to do this? And it's a little mysterious still, but the fact is that about 2 years before this, the UK came out with their own medical eligibility criteria. And so the CDC said, wow, we can't be outdone by England. They're surpassing us in so many things otherwise. Let's take a look at the eligibility criteria and see if American women might need to have the criteria tweaked a little bit for them. And so they did. And so these are the criteria that we're bound to use now. I think that you'll find very few people who refer to the WHO criteria anymore, even though the CDC and the WHO set don't really differ that much. But what this has done is given us the ability to change the criteria in a much more efficient and rapid fashion. So since 2010, there have been 2 more iterations of the criteria, and they've changed very specifically in terms of contraceptive methods for postpartum women. So looking at the methods that women might use immediately or soon after having a baby, or even after an abortion, and then as well looking at women who are HIV positive. So that's one thing that this new criteria has really given us, is a way to apply the evidence in a much quicker, much more efficient fashion. So the criteria are based on the contraceptive method, the patient characteristics, and any coexisting conditions. And as I said, the 2 there that are highlighted, postpartum and HIV positive women, were most recently changed. So they use a number scheme, just like we're looking at levels of evidence the same way, to talk about risk and benefit of use. And this is very different, because years ago, I'll go back again to my education, we talked about contraindications to specific methods, right? That's the language that we use. We talked about absolute and relative contraindications. Doesn't exist anymore. Now as providers, we're allowed to use our judgment, lo and behold, and talk about risk and benefit of various methods for particular women, which gives us much more freedom to safely use that method, and to safely use that method in terms of showing that we've applied our judgment for those particular women. And just to be clear, the recommendations don't apply to the off-label use of any of the methods for medical conditions. For instance, we know that a lot of women might come to us looking to use a combined hormonal method, the pill, the patch, and the ring, or hopefully even the Mirena, to deal with heavy menses. So they come to us and they say, I get really heavy periods, they're really close together, I get lots of cramps, I miss school, I miss work, can't you do something about that with a contraceptive method? And the answer is absolutely we can. And so that's an off-label use that the CDC criteria doesn't address. So there they are, 1, 2, 3, 4. And you'll see that that matches up with what's in your packet in terms of the colors. It's a really nice little color code there for the eligibility criteria. And you'll see in here that there's really no place that it says, this method is contraindicated for this particular woman. It talks about risks and benefits, which is a much more sensible way to do it. So these are the women that we know we would really like to have not get pregnant in an unplanned fashion, right? Lots of medical conditions, women who are on medication, women who have medical conditions that are not being particularly well managed, women who are not taking their meds the way that they're supposed to, women for whom an unplanned pregnancy would really be a bad and a dangerous idea, not only for them, but for their baby and even for their families. So these are women that we would like to have lots of conversations with in terms of, are you thinking about getting pregnant? When might that be? Well, let's make sure if it's not until 3 years from now that we do something very specific to make sure if you're sexually active that you're not going to get pregnant in that time frame. These are women for whom there are lots of contraceptive methods that are perfectly reasonable and safe to use. I think that sometimes women who have these kind of conditions think that there couldn't possibly be anything that would be okay for them to use, right? I'm taking medication. Won't there be a drug-to-drug interaction? I'm diabetic. Won't that method mess up the control that I have over my sugar levels? I have high blood pressure. Doesn't that mean I can't use contraception, right? And in their head, I bet they're thinking, I bet that means I can't be on the pill. But there are lots of other methods out there that they could use, right? Women who have cancer. We know that we're diagnosing cancer in younger women, that it doesn't necessarily mean that they're never going to have children, right? But during the time of their treatment, or even as particularly young women, there are times when we wouldn't want them to get pregnant. So I would say to you that these are especially women for whom we'd like to think about the long-term reversible contraceptive methods, IUDs and the implants, right? These methods are tailor-made for these women because there aren't drug-to-drug interactions. They work for a long time. They don't have to think about them. We can put them in, they don't have to worry about it for years on end. They can go about whatever treatment, medical regulation, whatever thing it is that they have to deal with, and don't have to think about their methods. Okay, so just to drive it home one more time, we talked about those ideal methods, and the thing that I would add into what that ideal method might look like is that most women would be eligible for them, right? That it would be safe for most women to use those methods. And believe it or not, for the implants and the IUDs, that's true. And you certainly pointed out that the things that aren't perfect about those methods at present are money. They're still very expensive. Compared to a year's worth of a combined method, like the pill, the patch, and the ring, on the other hand, it's not that expensive, but it's hard for people to think about that, and even sometimes to financially plan for that, to make it happen in that way. But by this time next year, this is when the new regs are supposed to roll out, all insurance providers are bound to provide all contraceptive methods, including the pill, the patch, the ring, the implant, everything, for no copay. So we should be seeing, hopefully, a change in people's ability to access those methods. And I really hope that we can spend the next year until those regs are put in place talking to people about those methods so that when those changes go into place, we're really ready to go and offer those methods to women who at present might not be able to afford them. Okay. So the Implanon is available at present. The Nexplanon should be rolling out. If you don't see it in your area, it should be rolling out soon. Just to kind of remind you what it is, it's a one-rod implant that goes into your upper arm. Takes about 20 seconds to put it in. It's really simple. We do it with a little bit of local anesthesia so that hopefully it's not painful. It might be a little uncomfortable, but it shouldn't hurt. And if it hurts, we stop. Give them a little bit more local anesthesia. It has a 0 user error rate, obviously, because it's there. Woman's not going to be able to do anything about it. And it has a 0 pregnancy rate. What could be better than that? So you know that when you look at the stats around the Implanon and the Nexplanon, you'll see that that pregnancy rate in every description of it is not 0. And that's because of a problem with how the Implanon was first manufactured, and it wasn't dummy-proof in terms of the provider. So quite unfortunately, it was possible for some providers to put the Implanon in, or thought they had put it in, when indeed the Implanon was still in the inserter than wasn't in the woman, didn't do a good enough job of palpating to make sure that it was in her arm before she left their office, she went away thinking that she had 3 years of protection, when actually she had 0 protection. And some pregnancies resulted because of that. The implant people caught on to that really quickly when those first few pregnancies were reported and changed the way that the device was manufactured for the providers. And now I can tell you it is absolutely dummy-proof. There's no way that you can make that mistake ever again, because they put little colors on the end of the implant so that you can see that it's actually not in the inserter anymore. But still, there are a couple pregnancies that have been reported with the Nexplanon. And why is that? And that is because we haven't done a very good job still of making sure that women aren't pregnant at the time that we put the implant in. So far, now this is the last 2 years of the Nexplanon use, this is worldwide, so this is thousands of women, all of the pregnancies that have been reported as a result of Nexplanon use or because the woman was pregnant at the time that it was inserted. So, for sure, we need to do a really good job of making sure that people aren't pregnant at the time that we're putting their device in. But know that, feel confident that this method absolutely has a 0 pregnancy rate when it's put in at the right time by a trained provider. Now, I'm sure that there are people here in the room who remember Norplant. Who remembers the horrors of Norplant? Yes, we all do. It was awful. It was terrible. People were so unhappy. Terribly, terribly unhappy, right? There were 3 rods. They were terrible to put in. They were hell to take out, right? Women had an incredible amount of irregular bleeding and came back to have them taken out in droves, had terrible experiences having them taken out. Norplant has one of the worst PR reputations out there. It was used in populations of women who probably weren't really sure about what they were getting. There were some really bad public health decisions made around who was to get the Norplant. And unfortunately, it remains as one of the kind of urban legends about implants. Nevertheless, we need to try to change our thinking about that and know that Nexplanon and Implanon are different. Absolutely. The biggest side effect is irregular bleeding, much less than we have with the Norplant, much less. And unlike the irregular bleeding that happens with Depo, which typically goes away after a couple shots, usually by the time the woman comes back for her second or her third Depo shot, that spotting that she was talking to you about has probably gone away, and she's probably pretty well amenorrheic by then. Typically with the Nexplanon and the Implanon, the irregular bleeding that people see at about 6 months is probably what they're going to see for the rest of the 3-year period. Nevertheless, for most women, that is nothing. They become lovely amenorrheic, just like they do with Depo, but there isn't that kind of gradual taper off of their irregular bleeding. Okay? Questions? Yes?
Weight gain?
Can't hear you.
Is it weight gain?
Weight gain. Weight gain, right. So, you're my patient. I make this speech at least 3 times a day, so I'm just going to make it. It comes out of my mouth like magic, okay? Weight gain from contraceptive method. Weight gain that women experience while they're using a contraceptive method is not the result of the contraceptive method, period. Okay? Weight gain that women experience while they're using the contraceptive method is not the result of the contraceptive method. It isn't, okay? It's not like a drug that you take that causes you to bloat, right? That causes you to have fluid retention. But Nexplanon, Implanon, Depo are all what? They're a progestin-only method, right? What do progestin-only methods do? They stimulate your appetite center. So if they stimulate your appetite center, and you respond to that by saying, oh, I think I'm going to have another scone today, and you don't change your activity level, you're going to gain weight. It's going to happen, right? But if you know ahead of time that if that happens to you, you need to either, start a new line of willpower in your life, or change your activity level, or something, or be okay with that weight gain. But that for sure, the method itself does not cause you to gain weight. It's the number one question that I get back. Thank you for asking it, because it's always the first thing that people ask, because it's what we're worried about these days in our country. We're not worried about dying of cardiovascular disease, we're worried about whether or not we're going to gain weight. But the method itself doesn't cause weight gain, no. We know that when we follow women over the long term, and with these kinds of methods, we're able to do that, because if they keep them in for as long as they're prescribed for, we can follow them, that there is a percentage of weight gain involved, but we think that that has to do with when you talk to women, well, were you hungrier? Have you changed your eating pattern a little bit? The answer is more than likely yes. We also know that we gain weight over time. It's a matter of aging. It happens. I'm here to tell you. So no, the method doesn't cause you to gain weight. But it's a hard sell. But compared to pregnancy, I think it's not such a hard sell. Questions? Other questions about it? Okay. So these are the women when we're talking about developing a reproductive life plan. And we talk about, what women say when we ask them, what are you thinking about in terms of having kids? And they talk to us about these kinds of things in return. These are the women for whom you should be thinking about Implanon and Nexplanon. I don't want to have a baby. 2, 3, 4, 5, 7 years. Off in the future, not right now. I'm done having kids, but the idea of having surgery, the idea of having a tubal, my partner won't have a vasectomy, I have more than one partner and I'm concerned about having more than one person, asking more than one person to have a vasectomy, not ready to do that. This is a method that should work for them. I hate having periods. How many people tell you that? I just can't stand having my period. It makes me crazy, right? Perfect, this works for them. I want to finish school first. This is a great method for yes, teenagers, and yes, college students. We're not used to thinking about these kinds of methods with young women. We're just not. It's a big shift in our heads, but there's no reason, none, zero. There's no reason why young women shouldn't be offered this method. There's none. There's no long-term side effect in terms of decreasing fertility. There's no long-term side effect in terms of changing her cycle. There's no long-term side effect in terms of bone density, right? There's no reason why we shouldn't be thinking about this method with young women, but we don't. Yes?
So I was just wondering, when you talk about long-term side effects, how much do you talk about possible long-term side effects of untreated chlamydia or gonorrhea in terms of fertility?
I think we don't. Right, so the question is, how do we match that up with talking about other long-term side effects of STDs or any other kinds of gynecological problem, ectopic pregnancies? We don't match it up that way. We have a tendency to take contraception and compartmentalize it, right? We only talk about preventing pregnancy. That's all we talk about. And I'm really hoping that as a result of today, thinking about talking to women in a much broader sense, no pun intended, about their reproductive life, that we might think about how contraception might fit into somebody's entire life plan, and not just thinking about it as a pregnancy prevention method for right now because I have a particular partner. Good comment. Again, those women who have an ongoing medical condition for whom pregnancy would not be a particularly good idea at present, and for whom we would really like to engage in some pregnancy planning and some medical management before they get pregnant. Again, women who've had multiple unintended pregnancies in the past. And what do they say to us? Well, nothing works for me. Nothing works, right? I've tried them all. How many women like that have you talked to? I've talked to a lot of them, right? I forget to take the pill. I don't like how that patch looks. It comes off when I use my lotion. The idea of putting something in my vagina, no thank you, right? Just, I don't know, nothing works for me. So please, widen your horizons about what you might offer to her. Okay, IUDs. Something with which we're probably a little bit more familiar. The two IUDs that we have on the market these days in the United States are the Paragard on your left and the Mirena on the right. And my little breathe deep and let go of things, I really mean it. I really mean we need to let go of some of those old ideas that we have about intrauterine contraception, right? So I learned that you never, ever put an IUD in a person who had never had a baby before, right? It was an absolute contraindication, as a matter of fact, right? Back in the old days, right? And you never put them in women who had multiple partners. Never, right? You never put them in women who are at risk of having STDs or had even a history of STDs. Somebody who had gonorrhea once in college and was 35 years old, she still couldn't have an IUD, right? That's what we learned, right? So that's what's still kind of, whether you learned it or not, that's what's still kind of hanging in the background in the provider world. And we know now, very firmly, we have excellent evidence that there's no reason that any of those women shouldn't be offered intrauterine contraception. Why? Because we know that intrauterine contraception does not have an impact on long-term fertility. It doesn't cause infertility. It doesn't. Okay? People say, well, that Mirena, you put it in there. I don't have periods anymore. I'm afraid that when you take it out, I won't have periods again. This is how I encourage you to think about that. Women who have DEPO, women who use DEPO, become amenorrheic as well. They don't worry about not having the ability to have children again when they go off their DEPO. They don't, right? They become used to it. They know their periods come back in whatever way their periods existed before they went on the DEPO, right? If they only had 3 or 4 menses a year before they started using DEPO, probably they're going to go back to that afterwards as well. Probably not going to revert to having menses every month. Same thing with the Mirena, right? Doesn't cause long-term infertility. Doesn't. Well, okay. All right. I'm with you there. How about those women who have multiple partners, about whom I'm really worried about STDs? The concern in the past was that somehow magically the IUD strings provided this highway, right, like the Holland Tunnel, into the uterus for gonorrhea and chlamydia, and that these organisms were going to fly up these strings and go out in her tubes and she was going to instantly have PID, right? Wasn't that what we thought about? That's how we looked at it, right? We know that that's not true. We know that that's not true now. We know that because we have more evidence in this country. Now, believe me, the rest of the world has known this for a very long time, right? Women in France, women in England, all over Eastern Europe. No, they don't worry about this. Right? But here in the United States, we have lots of worries, right? We're worried about things. We know now from evidence with our very own American uteruses that the presence of an IUD or a Mirena, intrauterine contraception system, does not predispose a woman to greater acquisition of STDs, including HIV. We know that that's not true. Just not true. It doesn't predispose her to transmitting STDs to her partner, so infecting someone else, either. It doesn't predispose her to PID. It doesn't. Okay? So there's no reason why we need to think about, in our very good sexual history taking that we're having with people, that if they have multiple partners, that we need to automatically cross intrauterine contraception off the list. No reason to, right? Okay? The only thing that we want to think about when we're putting intrauterine contraception in is we absolutely want to make sure she's not pregnant, right? Just like the implant on the next one. Absolutely want to make sure this is a woman who we either have on another highly effective method at the time of insertion, 2 weeks of abstinence, obviously a negative pregnancy test. However it is that you're going to decide that she's not pregnant, We need to make sure that that's not true. We want to make sure that she doesn't have an STI at the time of insertion, because we don't want to be that magical Holland tunnel up into her uterus when we put the IUD in. So for some women, that means having a negative gonorrhea and chlamydia test on board at the time of her insertion. Other people do it by history. Certainly not a requirement to have a negative STD test on someone's chart. Do it by your population, your patient. You know them better than anybody. Is it okay for women who are HIV positive to have an IUD inserted? Yes, yes, and yes. And now we have really firm evidence from the CDC reassuring us that that is so. Okay? Teenagers. It's okay for teenagers to have untreated contraception. I get so excited when I see a 17-year-old on my patient list for the day and she's here for her IUD insertion. It's a wonderful moment. She's going to have contraceptive coverage for years. 4 years. We can feel very, very comfortable saying to her, yes, now let's sit down and talk about sex. Let's sit down and talk about what's happening with you. But now we know that you're not going to get pregnant. Okay? Really important. Right? Okay, questions about intruding contraception? Yes?
You were talking about making sure someone's not pregnant, but what about using it as emergency contraception?
So the question was, what about using the Paragard, because that's the one that's approved by the FDA right now, as emergency contraception? Absolutely. I do it. We do it. It's one of those moments, again, when you have to be really thoughtful about the unprotected sex that that person has had, and if she is also at risk for having acquired an STI. So in that particular instance, she might not be a perfect candidate for using Paragard as emergency contraception. Again, we're not really sure why it works so well. It works better than Plan B. It works better than Ella. It works. So there's no reason why we can't add that to our EC list here in our country with all the things that we worry about in our own very specific litigious way. We don't see Paragards being used very often as EC, but there's no reason why we shouldn't. Yes? Mm-hmm. Other questions? Okay. So, breathe deep. Let go of all those old feelings that you have about IUDs. Try and acquire some new ones. Try and feel positive about them. They're good methods. Again, these are the same women. I'm not ready to have a baby yet. Not ready to think about it. Done having kids. Not ready for a tubal. My periods are driving me crazy. Now, if her periods are really driving her crazy, you might not want to think about Paragard, right? Because we know that one of the side effects of the Paragard is that she might have some increased menstrual bleeding, and that the Mirena might actually be a better choice for her in terms of deciding between the two. So I would just put that out there. Question? Yep, sorry.
Delivery, how long should someone wait to get an IUD?
Say it again.
How long after delivery of the baby should you wait?
So the question is, when can we put intruding contraception in a woman who's postpartum? Hold that question, because I'll get to it, I promise. Okay, that's okay. Again, these ongoing medical conditions, for sure. Again, there's no drug-to-drug interaction to happen here with intrauterine contraception. Nothing to worry about interfering with hypertension management, cancer treatment, all those wonderful things. Again, someone who says, I've tried them all, nothing works for me. This is just to let you know that there are a few little glimmers of hope in terms of American women maybe having some more choices in terms of intrauterine contraception in the future. On the left is an intrauterine contraceptive method that's widely available in Europe. On the right is a method called the Gynaflex that's still in trial, but we hope is going to be available soon. So the one on the left, you might notice two things about it. Three. One is that it looks a teeny little bit like the Dalcon Shield, right? It has those little, whatever they are, little protrusions, little things there. It's going to make people in the United States so nervous to see that. We're like, why did they have to do that, right? People are going to look at that and they're going to say, here we go again with the Delcon shield. So it makes me a little sad. The European manufacturers decided to put those on there. Nevertheless, you'll see two really wonderful things about this method of intrauterine contraception. One is that it's shaped like a uterus, right? Like, why did the Paragard and the Mirena people think that our uteruses look like this? They don't look like that, right? I've never felt a uterus yet in 30 years of practice that felt like that. They just don't, right? There's no like 90-degree angle up there. It looks a little bit more like this one, right? So this is called a multi-load. I don't know what that means. That's just the name of it. But it's shaped in the shape of a uterus, right? So you would think that there might be less expulsion because it can snug really nicely up against the fundus and kind of stay where we mean it to stay. Or if we're timid, we're a little nervous, when we put it in and we don't go all the way up to the fundus, hopefully as it moves around a little bit, it'll move up into the fundus where it belongs. And there's two sizes, right? So there's a regular and a small. Again, the small size might make us feel a little bit more comfortable about putting intrauterine contraception in no-lips, because that's for whom it's designed. It's designed for women whose uterus sounds to less than 5 centimeters. And that's typically no-lips. So here might be a, intrauterine contraception that we can say, okay, I feel comfortable putting this smaller device in this woman with this somewhat smaller uterus. And then the one on the right, the Gynaflex, is called a frameless IUD. So you can see there's no frame, that it's the copper wrapped around a silicone and metal wire, string, whatever it is, with this little teeny, I'm going to say screw, it's a bad word, but whatever, that we can put in, and it and we just get a little zips there at the end, and it adheres into the endometrium so that it stays in place. So you think, okay, well this is good, because now we have none of this kind of to worry about, right? It's a straight shot up to the fundus, but it means you need to get to the fundus, right? It means you can't be shy about going all the way up there to the top. Less expulsion, right? We think that it might stay in place a little better. And this also might be really good for women whose uteruses has some kind of anomaly, so it doesn't have that, kind of pear shape to it. Maybe she has a septum, maybe her uterus is a different shape, something. And now we, again, might have an option for her because we're worried about this kind coming out. So these are, again, the multi-load on the left, widely available all over the world. If you have patients who come to you from other countries, they might come with this kind in. You can see that it has, you can see that it has white strings, but I've also seen pictures of it with blue strings. So somebody looks in and says, oh, I've got this blue string thing, it might be this. And the Gynaflex is coming. Okay. So who's not eligible? So we've talked about both the Implanon and the Nexplanon, talked about intrauterine contraception. Take a look at your chart. So who's not eligible for these methods? Very few women. Very, very, very few women are not eligible for these methods. So I really encourage you to think about them, talk to women about them, ask women how they might match up with their lives, and think about changing our practice a little bit. Just to kind of whiz by combined hormonal methods here for a minute, these are the kinds that we have available to us right now, the pill, the patch, and the ring. And I put this graphic here about the pill because I do think it's a real burden. I think it's a problem that so many women feel like they have to use it because it's the thing that they feel the most comfortable with. And it's really a method that is just rife with problems, and we know that people stop using because they're not happy with it, and then they have unintended pregnancies as their major side effect. So it's a problem. However, here's your answer to your question about postpartum use. The biggest question that I have is, why do we wait until the 6-week visit to talk to women about contraception? We know that women don't wait 6 weeks to have sex. We know they don't. We know that on average, most women who begin to have sex after having a baby do so at about 2.5 to 3 weeks. That's way far away from 6 weeks in my mind. right? But we have this old tradition, yet again, about when we start seeing women postpartum. It's that golden 6-week visit time. And there's no reason, there's absolutely no reason why we shouldn't move that visit up to 3, 4, whatever weeks, but 6 is really not evidence-based at all. As a matter of fact, it's dangerous to wait until 6 weeks to start women on their contraceptive method. So, what we now know, and we're actually doing in our institution, we're putting intrauterine contraception in women on the delivery table, so to speak, post-vaginal delivery and post-C-section. It's really easy. It's really easy to put it in, I'll tell you, right? In, done, very simple. There's no cervical dilation that has to happen, especially if a woman has anesthesia on board. It's, you're done. You're finished. She has the baby. She has the placenta. We're done dealing with anything else that has to happen with her in terms of repair or bleeding. In goes the IUD, and we're finished. So the question always is, well, isn't there a higher rate of expulsion, right? We have this uterus that just had a baby. It contracts, down, into the non-pregnant size. Is there a higher rate of expulsion postpartum with IUD insertion? The answer to the question is yes, but it's minuscule. It's very, very small. It stays in there really well. It just does, right? So certainly you need to tell people that, and we need to be careful about checking for expulsion. She for sure needs to come back for about a 2-week visit to make sure that it's still in place, that we can see the strings and not feel the IUD sitting in her cervix. Although if it's sitting there, she's probably going to tell us, because she's probably going to be cramping like crazy. But there's no reason why we can't do it. So then you say, oh, post-C-section, are you crazy? Right? What about adhesions? You're going to put it in there after you've just sewn up a uterus that now really not only has to contract down, but it has to heal along that incision line. Aren't you worried about the IUD becoming implanted at the back of that incision because of adhesions? And the answer is no. Right? We don't seem to find a higher rate of malposition intrauterine devices, which is how it's represented in the literature, nor of expulsion with putting IUDs in women post-C-section. So the answer is we can do it right away, right? If they're not going to come back, if they're not going to want it right there on the table, but they're going to come back to us, we think that they should come back at about 3 weeks. The CDC is really good about being very clear about that in the guidelines these days, that's probably the good time when they can come back and think about starting on a combined method and think about having their IUD put in if it's not in yet. Right, so thank you. So can you do that if you're breastfeeding? The answer is yes. Again, another one of those no-nos that we always had, that combined hormonal methods were absolutely contraindicated in women who were breastfeeding, right? What were we worried about? What were we worried about? Right, that the hormones would go through the breast milk to the baby and that we would, give our male children pink dresses suddenly or something, right? That we would upset the hormonal balance of those, very newborn babies. And we know now that that's not true, right? We have really nice, well-founded evidence that the level of hormonal excretion in breast milk is minuscule to none, A, and B, even if it is there, causes no adverse effects in the babies. So what it does do, though, in some women, about 20% of the time, women report to us that they have a decrease in their breast milk production. So if you have a woman who says, oh my God, I could breastfeed 3 kids, what is with all this milk? I think you could safely say to her, and she wants a combined hormonal method, she wants to do the pill, the patch, and the ring, fine, no problem. This is good for you. Might even have a good side effect in terms of decreasing some of that milk, maybe. If on the other hand, she's somebody who's really struggling with her milk supply or struggling with how the baby's nursing or having some other breastfeeding issue, this might not be the best method for her in terms of using a combined method, but yes, right? So I have a lot of least favorite contraceptive methods, but my really least favorite is progestin-only pills. And because that's what we used to give to women who were breastfeeding, right? That's what people who wanted a pill, they wanted something they could do every day, that's what they were used to. We said they couldn't use the combined pills, so we gave them progestin-only pills. In my mind, progestin-only pills were an invitation to pregnancy because people got pregnant using them. What breastfeeding mother can have such a wonderfully predictable and rigid schedule that she can only have a 3-hour window in when she takes her pill? Not very many breastfeeding women that I know. So, I hope that the days of progestin-only pills for breastfeeding women are gone, unless she has some other good reason to not have a combined method. But for sure we can use them now. And no matter what it is that we're going to give her, unless it's the implant or an IUD, please don't forget about sending her home with some EC. There's no reason why postpartum women at any time, 1 day, 1 week, 1 month postpartum can't use EC. And certainly, we know that women stop their combined methods, so for sure they should be getting EC as well. Questions about that, postpartum? So just a little bit about what's happening with the combined methods, most especially the pills. I feel pretty safe in saying that there are new oral contraceptives coming down the pike, that we're going to have to learn about some new ones, some new names, how they're used. But I also feel pretty safe in saying that none of them anymore will ever have 7 hormone-free pills in the pill pack ever again. We know that the biggest reason that women who are taking oral contraceptives who don't intend to get pregnancy do indeed get pregnant is because there's some screw up there with that last week of pills, right? Women have this idea that they get to the end of the pill pack, they get to the end of that 7 week of hormone-free pills, and they're still bleeding. It means that they shouldn't start their next pack. It means that they should wait until they're done bleeding and then start up a new pack of pills. And we know that that's absolutely not true. We know that 7 days without any combined hormonal method with the pill, the patch, or the ring puts women at risk for pregnancy. And so the pill manufacturers and developers have finally caught on to that, and never again will you see that. So what we're seeing instead is a taper down dose. Now you're seeing 3 days hormone-free, 4 days hormone-free, and in the newest pack, only 2. And even if you don't want to use, any hormone-free break at all, there's no reason why you shouldn't use all the methods, the pill, the patch, and the ring in a continuous fashion, and not have any withdrawal bleeding at all. So I put a couple other of the newer pills up here for you to take a look at, just so that you would know about them. So the ones on the left, Safril and Biaz, are the new versions of Yasmin and Yaz, right? Yasmin and Yaz were wildly successful as oral contraceptives, but they are now generic, right? So the manufacturer said, okay, we need to keep our patent happening here. How can we do that? And they came up with what I think is a pretty good idea for once. They decided to put some folate in their pills. Now, why is that a good thing? Right? Why is some B vitamin a good idea in a pack of oral contraceptive pills? Well, what's one of the main messages that we want to give to women in our preconception health education? Starting them on folic acid. 400 micrograms of folic acid. Every woman of childbearing age who's sexually active, who thinks that she might be thinking about getting pregnant, who is thinking about getting pregnant, or who is at risk of an unintended pregnancy that she might decide to carry to term, hopefully, should be taking 400 milligrams of folic acid. And so this particular pill manufacturer has said, okay, we get it. We get that people forget their pills. We get that women have unintended pregnancies on combined oral contraceptives. And we get that it takes a little while for that serum level of folic acid to build to the place where it becomes useful in terms of preventing neural tube defects, which is why women are on folic acid to begin with, right? So let's just build it into the pill. So they have. I think it's a great idea. And I think it's also a great kind of health education teaching moment. This is why this pill is different. This is what it has in it. The calcium folate that's in there is equivalent to 400 milligrams of folic acid. chemically equivalent, and this is what this means for you. So I think it's a really nice way to kind of weave, again, that kind of pregnancy planning piece into contraception planning. So the pill on the right, Natassia, is a new pill. It's only available in brand name. It's only been out, I would say, in common use probably for about a year. And I don't know if you can appreciate this from the picture, but usually the chemical that's in the pill changes when the color changes, right? We've gotten used to that. So you can see there's lots of color changes in this pack, and that's because the hormone dose throughout the cycle of Natassia changes 3 times. And it's not in that kind of tricycle that we're used to with orthotricycline and all those other things that we've had for a long time. It goes up and it goes down, and the idea is that it kind of primes the ovulatory system at an earlier point to prevent ovulation, keeps it there, and then just tapers it back the teeniest little bit at the end. So far, this is the combined oral contraceptive that has the least amount of hormone-free pills and the least amount of hormone in the hormone-free days. So it's out there. It's confusing to describe to women what should happen if they miss a pill in the Natassia pack, because it's not as simple as take it the next day or take 2 the next day. It's got a very different dosing system because of the hormone design. And it doesn't work any better than the rest. It's just a researcher's idea about how we might manipulate hormones. A couple other methods that are coming down the pike soon, I think relatively soon, a progestin-only ring. So again, for women for whom there's a contraindication for them to use estrogen or don't want to use estrogen, there should be a progestin-only ring relatively soon. There's going to be some competition for the Nuva ring. So there's going to be more combined rings out on the market. And there's going to be a really new ring that's still in trials, but I think is probably coming as well, that's got ulipristal acetate in it. Ulipristal acetate, ring any bells for anybody? We know it as. We know it as Ella. We know it as the other emergency contraception other than Plan B and next choice, the progestin only. This is a different kind of progestin. We're calling it a progestin-releasing modulator, so it works in a little different way. But they're looking at that in terms of a new contraceptive ring. So just know that they're coming. Just in case you don't know it, the sponge is back. When the sponge was on the market, again, this was, back in the day. When the sponge was on the market, believe it or not, I have a hard time convincing my students of this, but it was the most popular contraceptive method that was on the market. It was. Women loved it. They thought it was great. You could buy it in the drugstore. You didn't have to go to the provider's office. It was cheap. It was easy. It was one time. It was discreet. It was comfortable. Not a problem. And they made a Seinfeld episode. I mean, what could be better marketing than that, right? It was taken off the market as well. Had nothing to do with safety. Had to do with the manufacturing process. The people who were manufacturing it decided to go out of business. A company in Canada took over. It is now back. People don't know about it. It really needs commercials. But it's another thing that you might remind people about who are in between methods, stopping a method, don't want to take a method with them, need something, has, we think, the teeniest bit, I hesitate to say it, the teeniest bit of protection against STDs. Not great, but some. But it's back. It's there. Another thing that we're thinking about, people mentioned having a contraceptive method that might prevent STDs. You all know about microbicides way more than I do. You know where we are in the development. We're kind of stuck at the moment, I think. But there's also a new kind of one-size-fits-all, it's not new at all, diaphragm called the Silks, S-I-L-C-S, that's manufactured by the Path people out in Seattle. And it is, again, kind of been hooked into the microbicide world, and we're hoping to see a microbicide-impregnated barrier like the Silks or the Silk itself being tested soon. We know, I think I've mentioned this all the way through, for women who are HIV positive or who have AIDS, really think beyond the pill. The pill is probably the worst method for women who are on ARVs, right? Lots of drug-to-drug interaction. We know that there are some that are absolutely safe, others that you probably shouldn't use. But for sure, these are women for whom you should think IUDs and implants. CDC says so. It's finally out there. It's just released in July. Very new recommendation, but well-based and lovely evidence. So which is best for you women with HIV? You know, that's up to her and to you to think about. Obviously with condom use if we're worried about transmission. But please, please think beyond the pill. I think I already said this. I'm not going to repeat. There are lovely charts out there of which drugs to use with which. So certainly there are some that are safer than others. I already said that. So just for a couple seconds about preconception care, and then we have some time for questions. So as I said before, and as you all know, it's not a secret, our statistics are just terrible, and we really need some new ideas about what to do about them. We really need some new ideas thinking about pregnancy prevention, about pregnancy planning, and about taking hold of women for whom we know that an unplanned pregnancy would be a medical risk, taking them into a framework of care that might help them think about how they might best plan for that. We're also really worried about what's happening with obesity in this country because we're starting to see some pretty interesting research on pregnancy risk for women who are obese. We know that, in our heads we thought anecdotally and without a whole lot of evidence behind it that women who were obese probably did have a greater risk of pregnancy complication and adverse birth outcome, and now we have research to say that that is absolutely true. So certainly for those women as well, especially if they have obesity and some other condition happening at the same time, we for sure need to think about trying to help them think about planning their pregnancy in a way that makes the most sense for their health. I'm sure that you have gotten wind of or know specifically about the changes in the way that we put together our, again, they're not annual visits anymore, but our periodic well-woman visits, the new phrase. We know that we don't need a pelvic exam to start somebody on a contraceptive method. Absolutely not necessary. We know that we don't need to do a speculum exam for a contraceptive start, nor even for STD testing anymore. We know that we shouldn't be doing PAPs on anybody before the age of 21. Absolutely, positively not. No way, no how. And that it's every 3 to 5 years after that. So it's not an annual pap smear anymore, not in any way, shape, or form. We need to make sure that people understand that we're doing it because it's based on the evidence. We're not shortchanging them. We're not denying them something that would make more sense for them to have. It's hard for women who are used to that routine, though, to say, wait a minute, where's my pap smear? But a lot of those women, I think, are under the misimpression that a pap smear does more for them than screening for cervical cancer. I think a lot of women think that pap smears are an STD test, and they're not, obviously. We know that there's no reason yet to be thinking about doing breast exams on anybody before 20, probably before 21, and that they have very limited value after that. We like to think that we've got really good hands and that we can pick things up early. The fact of the matter is that we can't. We're just still not very good at it. And so, the idea, again, of people having to have a breast exam every year has really gone by the wayside. It's hard to think about, it's hard to change, what we prepare people for, but it's the truth. So, putting that all together with all the things that I've said here this morning, I would just ask you this question that I pose up there. We know that the leading cause of mortality for teenagers is what? It's accidents. It's not cancer. It's not STDs, right? It's accidents. How many times do we ask our young women, do you wear a seatbelt? Do you wear a bike helmet? Are there weapons in the house? Do you feel safe at home? How often do we ask them those questions that actually might have a huge impact on their lives? I would say probably not very often. Leading cause of mortality for women under the age of 40 is cardiovascular disease, right? How often do we really talk to women about what happened when they stepped on the scale out in the hallway? About what's happening with their diet? Do they exercise? What does that mean? How might they change their lives? So I would say to you, if you could talk to every woman about just one thing, just one thing. I mean, we don't have time to address the whole list ever anymore. But, think about what that might be. We have time to do it now. She hardly has to get undressed, for goodness sake, right? We have lots of time to talk to women in those exams, in your counseling sessions, in preparing her for coming to see me. Think with her about the kinds of things that you might be able to say to her, right? Here's a whole list of things. I really look to you to dispel those myths about contraception, about setting women up for what they might come and get from me. Thinking them about contraception care, that is way within your scope of practice, right? Thinking to them about how they might get that folic acid on board, how they might think about diet and lifestyle to get themselves healthy before they're pregnant. I didn't talk about men today. That's certainly a part of preconception care. It's certainly a part of reproductive life planning. I'm sure the Dalai Lama would agree with that. But as much as you can involve partners in what it is that you do, I encourage you to do that, and I'm sure you will. So these are the goals from the CDC in terms of reproductive life planning, in terms of preconception care. They encompass all the things that we talked about this morning: contraception care, getting to a place of optimal health before they get pregnant, reducing their pregnancy risks by addressing all that before they get pregnant, and certainly reducing some of the really glaring disparities that we have in adverse pregnancy outcomes these days. Okay, I think we have a few minutes left for questions. Yes?
I was just wondering what your opinion is on the still not use of pill for men. Looking at using
About what?
a pill, contraceptive pill for men, to get away and become
So there's a lovely pill for men. It's in China. They're actually using it to a slight degree of success, absolutely. Okay, I'll talk to the men here in the room. What's the problem, guys? Like, what are you worried about, right? American men are really nervous about doing anything that messes around with their stuff. They are. Talk about a PR problem. Talk about a PR problem. It exists. I think that American researchers have just not jumped on the bandwagon because they know what a huge PR mountain they have before them. But yeah, it exists. Yeah, there's some really nice sperm blockers that are out there. That's what they do. Yeah. Mm-hmm.
Are all of those contraceptive methods available in the U.S.?
All of which contraceptive methods?
You talked about today?
So the question is, are all of the contraceptive methods that I talked about today available in the U.S.? So what's available here in the U.S. are the ones that I think that we know about. So the pill, the patch, the ring, the sponge is certainly widely available. The silks is not. It's here in the U.S. It's being used in research studies, but it's not widely available. Implanon and Nexplanon are. So the difference between Implanon and Nexplanon is only packaging. It has nothing to do with anything else. So hopefully you're going to see the Implanon transitioning into Nexplanon. It's not as easy to say, but it's what's out there. Paragard and Mirena for sure. The other kinds of intrauterine contraception, not yet. No. Yes?
What replaced anoxylon and spermicidal?
So the question is, what can replace dinoxyl-9 as a spermicide? Is that what you? I think nothing. Unless somebody knows differently than I do. Yes? So I think the answer is there isn't, right? It's still what it is. It's still what we rely on.
But it said not to use it because it increases the risk of HIV.
Right, so we're trying to carefully select who we recommend anoxyl-9 to, and that's why we're looking to the microbicide research to give us something different instead. And we thought we had a hold of a couple of those, but the stage 3 trials just haven't gotten us to the place that we wanted to. So there isn't anything yet. Sorry, there was another question in the back?
My question was on the
You're gonna have to speak up.
how long does it last to extend for a year? So once a woman decides that
Okay, so I didn't exactly hear everything. You're talking about the Implanon, or you're talking about IUDs? You're talking about the Implanon. Right, so, so the turnaround time from the Implanon is actually shorter than that of DEPA in terms of resuming the kinds of cycles that people would typically have had before they had the Implanon inserted. So, you know, I think that we give the same advice that we would typically with any kind of progestin-only method, and that is that we encourage women to at least give themselves a couple months, so 2 to 3 months, to resume a normal ovulatory cycle before they start trying to have a baby, just to make sure they have their highest chance of ovulation and conception. But if a person got to the end of her 3-year period and had the Implanon taken out and wants to have a new one put in, at that exact same moment. Take it out, put the new one right in, right there, instantaneously. Yeah. Yes?
You mentioned outreach to young people, children, teenagers. What are the ages? Maybe this outreach to you, that's number one. Number two, are the families considered when you talk to them so that they can understand the awareness of using this contraceptive?
So the question is about teenagers, and when we're starting to think about outreach in terms of contraceptive use. And I think that, you know, that the United States is a, 50 state. Every state does things the way they do things. And so the idea of having, family life, contraception curriculum, whatever it is that we're going to call it, in the schools varies from one state to the next. I live in New Jersey, and in our state we start in the 3rd grade. And I think that's a good thing. When we start out easy, we build them up so that by the time they're in 5th grade, they understand what contraception is about and why we might want to think about it. That's pretty young, but on the other hand, we know that the age of sexual debut in this country is dropping, and it's probably somewhere between 12 and 14. So I think that that's not an unreasonable time to start thinking about it. In terms of involving families, we always hope that those, sex ed curriculums involve stuff that goes home and sessions with the parents as well. I think that that, again, varies on an individual basis. And, I think it's really hard to predict what that means. We know that in the United States, though, teenagers can access reproductive health services without their parents' consent, if that's what you're asking me. All 50 states. Last question. Yeah, last one.
Okay. Because of what you said about outreach and families, one of the things that we always have to think about is that sexuality or sexual expression is not always consensual. So when we're providing young people with the information about this and STIs and other things, it's also for those who are in situations where they do not feel they have a choice to say no.
Yeah, I think that's a really important point in terms of thinking about women of any age, and not even just young women, but thinking about their own agency in terms of their sexual health decision-making and reproductive health decision-making. And again, I think that's another reason why, some of these methods, I'll just beat the drum here one more time, like IUDs and Implanon are really important for women, is because nobody can screw it up for them. Nobody can sabotage their method. Because nobody can take their pills away or their patch away if that's not what they're using. And I think that that's yet another piece to kind of put into all of that as well. Thanks for bringing that up. Yeah. Okay, thank you all very much.